Hey everyone, I'm Jeff Sorensen, co-founder and director of Optimize, a student-led social innovation community at the University of Michigan that provides support, mentorship, and funding for students to turn ideas into impact. And this is the Why Not Me podcast, where I speak with entrepreneurs, activists, researchers, and leaders from all walks of life about how they're using their life to make a positive impact in the world. My guest today is Hitinder Gurm. He's a cardiologist and the chief clinical officer for the University of Michigan Hospital. He also pioneered a statewide collaborative initiative that has vastly improved outcomes for cardiovascular patients across the state of Michigan over the past 20 plus years. And he's a constant innovator in the heart health space with his name on 5 patents and counting. In this episode, we talked about what it was like to be in the command center for the Michigan health team when COVID hit. And we talked about America's continuously evolving approach to COVID. We talked also about Hitinder's experiences living in India, the UK, and the US, and their varying medical systems, and the advantages and disadvantages of each. We talked about leadership, finding purpose in an organization, and advocating for your own advancement within an organization. And then we spent a lot of time talking about diversity, equity, and inclusion in medicine, why non-traditional students can be so successful and such strong contributors in academic and professional settings, and finally, how Optimize has sought to tap into and unleash that energy in our own context. I hope you enjoy the episode as much as I did. Thanks so much again for listening. Well, I guess we just get started then.
Go for it.
Thanks for making the time to be here with me. For the listeners, my guest today wears a lot of different hats. He's the chief clinical officer for the University Hospital. He's a cardiologist. He's also my father-in-law, soon to be father-in-law, I guess. But I already call you that. So.
Well, that's the most important role that I have in my life.
Yeah. Well, so we've got a lot to talk about, and I think where I wanted to start is a topic that everybody is probably interested in, and that everybody's been affected by, which is that you were in a leadership role. You still are, but when COVID first became something that we knew was going to be serious. And I actually remember that we were together in India when the news was starting to come in that, oh, wow, this is going to hit the United States. And you were getting texts and messages from your colleagues saying, you might want to consider coming back sooner than you planned, and we need to be back preparing for this. And then, in the weeks that followed, I moved in with you guys, and we were in the same little bubble. And, you were basically in the command center every day, just trying to figure out, with your colleagues, how do we respond to this? Can you walk me through a little bit what that was like? Like, how were you? I was perceiving you perceiving it, but how did you perceive it at the time, the sort of development there?
So COVID was, for many of us, the biggest professional challenge that we had never anticipated. And it was something that, you might have heard the cliche, it's 1 in a 100-year event. And it clearly was. None of us anticipated that we will have a new pandemic, a disease that we had no idea about that will go across the globe and will keep coming back. Mm-hmm. So when it first came, maybe we were a little fooled by how it had been dealt with in China, which is a very different government, very different society, very different rules, and also unclear about information. We knew that it was going to be a big problem. What helped was everything else shut down. So all the focus was on dealing with COVID.
Right.
Everyone was thinking about COVID. Everyone was planning about COVID. Everyone was coming up with solutions, how we were going to tackle the increased demand on our system. And the second thing that happened was the sort of level of collaboration that quickly appeared across organizations. So not only within the University Hospital or at Michigan Medicine, where we were dealing with COVID, we were talking to colleagues in other hospitals and helping offload, especially in the greater Detroit area, because they had such a greater burden of COVID than we did.
Right.
That to help them bring their sickest patient to our health system so that we could care for them. And then as this evolved further, we had to think about how do we help smaller hospitals take care of patients that are presenting to their emergency rooms because the larger hospitals were filling up. So it was a challenging time, but it was also a greatly satisfying time because I feel as a group, and as a group I mean the entire healthcare systems, not just at Michigan Medicine, but across the state, they really rose up to the occasion, and they really made a big difference to many people's lives. It was also a sad time. I lost a lot of my patients. Patients I had cared for a long time, and some who I felt were really at risk did fine, and their family members who were not that sick ended up dying. So it was sad, and for those families, it's even sadder because they've lost loved ones, and I think all of us have been affected in many ways, but the people who've lost loved ones have been the most deeply affected.
Yeah, for sure, for sure. How was that sort of? Was it your job already requires you to compartmentalize a lot? So you'll be having dinner with family, and then you get a message that, oh, I need to go help someone who's having a heart attack, and then a few hours later you're back again with family, right? It requires a lot of compartmentalization. Was that any harder during those early days of COVID? Like we were on family vacation when it really started happening. I remember when we landed in India on March 1st, almost no one was really that worried and really wearing masks or anything like that. And when we left on March 10 or 9, everyone everywhere was wearing masks and everyone was like, it's coming. And so that's like a pretty drastic shift of how everyone was perceiving it. And I think it took maybe a few more days for a lot of people in the States to understand how serious it was. But within a week of that, the country was basically shut down. Was that any harder to compartmentalize that experience, like being on vacation with family? And then I think you knew before we knew that this was going to be really serious. But I didn't get that sense from you necessarily that you were really like even in the weeks after when we were living at your house, you would come home and it didn't seem like you were any more off keel than you were even keel like you had been. So was it a continuation of just the sort of practice that you've built up at learning how to compartmentalize that, or was it actually harder?
No, I don't think it was any different. That's a very good question. I never really thought about that. And part of it may be that, I'm an interventional cardiologist, and we interventional cardiologists deal with very sick patients for very short periods of time. And we deal with people we've taken care of for a very long period of time. So we are used to seeing that. And that just becomes the norm. And you have to take care of patients when they are very close to death. And if you panic, then the patient's risk of dying goes up a lot. And most interventional cardiologists that I know, everyone that I know, stays calm under moments of great stress. I think that is a learned habit, and that I never reflected on that, but I think that helped during this crisis because it was just dealing with another challenge. The difference with this one was it was not somebody having a heart attack from which they were either going to get better in like 99% of the cases, or I would say 95% of the cases, or they were going to die, but an ongoing societal challenge that was going to keep coming back.
Yeah, totally. I think that's, from what I've heard, I'd be curious to hear your sort of perspective on this. That sense that like this is just going to keep coming back and it's going to drag on and on and on. I don't think we actually knew that at the start. Like what did you think was going to happen at the beginning? Because I think we all thought it was going to. I remember when we were sort of saying goodbye to our team the last day we were in the office, when it was like the NBA canceled their season and everyone all of a sudden was like, oh wow, like everything's going to get shut down. And I think the next day the university decided to cease all in-person educational activities. And I remember people saying like, oh, I'll see you in April or something. And they thought that was long. And I was like, you guys, I might not see you till September. But I was thinking September 2020. And I thought I was the one being dramatic, And then obviously it actually was a whole additional year before we really got back to in-person stuff. And now we're still dealing with it. What I've heard is that a lot of healthcare workers in those initial weeks and I felt this a little bit too. I was doing that mutual aid sort of society right off the response, and there was almost like an adrenaline to it of like, we're here, we're important, we're on the front lines, everybody's supporting this, we're all in. But then there's sort of been just a slow shift over time where people are just sort of saying, how long can we keep up that kind of energy? And I think the messaging has had to change, and the leadership tactics have had to change. How did that look from your perspective with managing just your own changing understanding of how this was going to look, but also then recognizing that all of your people in the Michigan medicine team, the nurses and the doctors and everyone who's there, all the employees, are going through that same kind of experience. Has that turned into an almost harder problem than just the logistical challenge of where do we have beds available and how do we move patients? Obviously, that's hard too, but
it has. And I think, I want to go back to what you just said. How did people respond initially? What was impressive was we had a disease from which we knew very little. The early reports suggested very high mortality because we weren't diagnosing every patient, so we only heard about like the sickest patients. And we saw, even in our own experience, very early on, very young people or people who were otherwise very healthy die very quickly.
Mm-hmm.
But what was impressive was that there was this incredible sense of volunteerism. So people volunteered to take care of these patients. They came from other areas which it would not have been their normal job to take care of COVID patients. They all wanted to take care of COVID patients. So we had no shortage of people who were willing to take care of them. So that was just gratifying and humbling. And our organization put in some rules that people who were at higher risk due to health conditions or their age and other factors, they were told not to take care of COVID patients. And they felt almost like they were not living up to what is their professional duty. So in private conversation, some of those colleagues had mentioned that they almost felt guilty when others were taking care of these patients that they were not. And there was also the societal support. You saw signs everywhere, hail the healthcare workers and all that. But as this pandemic has dragged on, the perception of this has changed, right? So the world goes on, the hospitals are full. We've had this during the subsequent waves. We especially saw this during the Delta wave. During the Delta wave, our hospitals were full, emergency rooms were full, but the rest of the society was moving along just like normal, right? We were having, and the need to. I actually think that it's important that society moves on because life has to go on, right? We cannot let a virus shut us down forever. We have to be able to live. We just have to live with the virus, and we have to adjust and evolve along with the virus.
So, do you think that message has been? How does that feel for the team that is still on the front lines at the hospitals? How have you seen that change the way that people are engaging in this? We've heard about the great resignation across all industries, but has that been happening in your team as well? Team broadly speaking, in the university hospital?
Yeah, healthcare systems are struggling with staffing shortages, and there are many reasons for that. One, just the significant burden that COVID brought to how much people had to take care of, how much they had to work. That has physically exhausted a lot of our team members. So that has been one issue. The second has been how COVID has become politicized. That has had some impact on how some people feel that everyone should get vaccinated. And there's been some concern about compassion fatigue. Like they feel, and we have to go back to, we don't, in healthcare, one of the first rules is you don't judge why somebody is ill.
Right.
We take care of patients irrespective of why they're ill. If I felt that patients who are not responsible for their own healthcare and didn't take care of them, well, half of my work would go away. But then I would be not treating half of my patients, right? So the biggest avoidable risk factor for heart disease is smoking. People smoke. It's our job is to counsel people not to smoke. It's our job to advocate for public policy that encourages non-smoking behavior. But when a smoker comes with a heart attack, we have to treat them just like we would treat anybody else, you, me, our best friend, our family members, right? So we have to do that. But it becomes harder when the hospitals are full and other people's care is being impacted. So that has created a lot of moral stress for many of our colleagues. And that has been a huge challenge lately where we have not been able to accept patients for whom we would be a center for last resort. There are patients whose care needs are so complex. They are from other organizations in the state, in smaller hospitals, and only a few hospitals in the country can take care of them. University of Michigan is one of them. But we are not able to bring those patients because we are too full. The problem is when we are too full, other hospitals in the state and elsewhere, even in Ohio, say Cleveland Clinic, they were also dealing with the same problem, and these patients have suffered as a result. So that has been hard to see, and it's hard because you can't do anything about it.
Right.
That's the challenge. You can only treat people that are in your hospital. When you cannot help patients who are elsewhere, it becomes very hard when you know in different circumstances that patient would have lived or would have had better outcomes had we been able to bring them and take care of them.
Right. And I think this has become one of the most, the hottest political issues at this point. And sometimes you see political issues and you think, wow, this is just trying to divide people over something that shouldn't be dividing people. But with this one, it really feels like a serious ethical question that is hard to resolve of how do you prioritize if you're at max capacity. Right? I mean, so has the approach changed at all as this has, as after vaccines became available? Is that something that, how are those decisions thought through?
Yeah, very tough question. And, we actually, even before the pandemic, have had to deal with a greater demand than what our capacity can take care of. So we've always have had a set of principles that help guide the person who has to accept the patient in defining which patient gets prioritized.
Yep.
And it's just purely based on patient need.
Okay.
We keep one of the things that I'm really proud of about University of Michigan Medicine is that patients' ability to pay or their insurance status is not at all supposed to be considered in making a decision on who do we bring over. So whether you are a person who has no insurance, no money, or you are one of the richest people on the planet, that does not help you one way or the other.
Yep. But how do you prioritize sort of, is it about urgency?
It's totally about urgency.
Okay.
It's really about urgency and taking into account what access we have. So it becomes like, if we have beds in the cardiac ICU, then obviously we have the team that's used to taking care of cardiac patients. We cannot bring in a surgical patient in the ICU. But if we have a patient who has cardiac needs, we will bring them. But it's really the patient who is the sickest gets priority as long as we have the ability to provide care and we have the right care team to take care of those patients.
So did COVID change a little bit? It maybe not change the principles, but almost change the rules a little bit on this, because there was a time, at least in the beginning, and I don't know if this has happened on subsequent waves or not, but I remember at the beginning that basically all of the beds of the hospital were converted to COVID beds, right?
Not all, but a substantial portion were converted to COVID beds. And that's true. During the first wave, the hospital almost became a COVID hospital. One of the interesting facts that happened during that time was there was a substantial decline in people coming to the emergency room with things like even heart attacks. It was probably related partly to patients not availing themselves of medical attention because they were afraid that if they went to the hospital, they'd get COVID
there. Yeah.
And that probably played a role. But in subsequent waves, that has not been an issue. So we've managed both COVID and non-COVID. But COVID patients are treated just like any other patient. So a patient with COVID in another hospital would be thought of like a patient with cancer or heart disease, kidney disease, or other illnesses. It's just another disease at the moment. And we don't prioritize one over the other. So every patient is seen as an individual and is prioritized based on their needs against the resources we have. And if we have the resources, we would then help bring them over.
So how has that shifted though? If in that first wave, it basically, because you mentioned this is a nuance that I hadn't thought about before. That okay, you're thinking about overall capacity, say approximately 1,000 beds at University Hospital, but about or 900 something, right?
Yeah.
But those are not just like blank slate 1,000 all the same. It's like you've got your cardiac ICU, you've got your other. What are the different units actually? What are those different segments during a normal time?
Yeah, so think of the hospital. There's the adult hospital, then there's the children and women's hospital, right?
Yeah.
So the adult hospital takes care of adults.
Yeah.
And within that, we have what I would say are general care beds, the intensive care beds, and moderate care beds. So within those beds, the ICUs are probably the most specialized. So we have medical ICU, we have a surgical ICU, we have a cardiac ICU, we have a neuro ICU, and then we have cardiothoracic surgical ICU. So the cardiothoracic surgical ICU is where patients would go after they've had heart surgery or vascular surgery or lung transplant or things like that. The surgical ICU is other surgeries other than this. The neuro ICU is people who've had problems with the brain and nervous system. So the neuro ICU team is really good at taking care of neurological problems. But during COVID, they actually took care of COVID because it's a new disease.
Right.
And everybody learned it just like anybody else.
Yeah.
But if a patient in another organization has a neurological problem and we don't have beds in the neuro ICU, bringing them into our cardiac ICU is probably not best for the patient because the team doesn't have the expertise and the skill set to provide care to that patient.
Yep. So you're looking at not just across the board how many beds are available, but is the right bed available?
That's right.
And so your own path, to take a little tangent here actually, to give maybe a little bit more context for listeners on what does it actually mean to be the chief clinical officer of the university adult hospitals. Your path actually came up by initially being a cardiologist, then going to a role where you were in an associate administrative role for the Cardiovascular Center and the neuro wing, right? And then into a role that covers adult hospitals, including cardiovascular and neuro. Is that approximately right?
That's approximately right. So let me take a step back.
Yeah.
So my foray into administration started with a role very early on when I joined the University of Michigan as the director of our inpatient cardiology services. And that came about simply because we were recruiting for a director at that time. And the people, my chief asked me to interview some people. I did, and I was like, they're not that good. I can do the job better. I went and told the chief that. And he said, well, I like that. So he ended up giving me that position. And from that,
I want to explore that for a second, actually, too. But you continue.
Right. So I did that for a few years. And then I was asked to take on the associate chief for the Division of Cardiovascular Medicine and the chief of cardiology at our VA, at the Ann Arbor VA. So I did that for
a dual
a few
role
years.
at the university and the VA.
That's
which,
right.
For those who don't know, is just down the road, basically.
Yep. It's just like about, I would say it's probably about a mile or a mile and a half or so from the university hospital. So I did that for a couple of years. And then there was the administrative position of the associate chief clinical officer for our cardiovascular neuroservices, which was working with an administrator and a nursing leader to oversee the clinical operations of our cardiovascular center and the neurology units. And then last year, I took on the leadership role as the chief clinical officer, which is overseeing the clinical operations of the entire adult hospital, along with an administrator and a nursing officer. So what a chief clinical officer role is really to oversee all clinical operations as to the patient's journey, focus on safety, quality, efficiency, and patient experience. How do we ensure that the patient has the best quality of care, but also their journey through the system is progressing as it ought to, balancing the wellness and the experience of our teams. So it's
Right.
there are two parts to a health system, right? The people who take care of the patients and the patients, and we need to take care of both of them.
Yeah.
That's our job.
That's very beautifully put. And how does that role that you do relate to? You said there's a nursing administrator as well, and then the third one. And what is the third one in the?
They're like
triad?
an administrator, so
Okay.
they're like a pure a business person.
Okay, got it.
It's there's a chief nursing officer, a chief operations officer, and a chief clinical officer. So the three of us oversee the adult hospital.
And then there's the sort of chief medical officer. How is that related to these roles?
Yeah, so traditionally, if you go back about a decade ago, there used to be just one chief medical officer who oversaw everything. And it became very clear that the job was too big for one person to do that. So the clinical operations have been split off, and the chief medical officer oversees lots of things, including the staff privileging, who gets to work in the hospital, how do you ensure that they are they have the right skill set, and you credential them. Also the safety and quality, our relationships with other organizations. So it's these roles are evolving as to one versus the other.
Yeah. And is this something that a lot of hospitals have used this model now, or is this sort of is Michigan kind of trying this out? You know, how's you said only in the last 10 years. I didn't actually know that.
Yeah, so the smaller hospitals still have a chief medical officer, but most large health systems have now created these dual roles.
Okay. We're so far on this tangent that I might not even know how to get us back, but this is really interesting to me too. So without going into anything that is, immediately sensitive or anything like that, I think it's really interesting that there's a nursing lead, a clinical lead, and a business lead that essentially are working together to manage, one of the top hospitals in the country. So you could think of this as a model that probably is happening elsewhere too, right? And so what are the tensions in sort of different goals, and how do you work together to resolve? What are some of the biggest tensions? So you come in and you say, from my perspective, and to do my job responsibly to the mandate I have, here's what I think should happen. And then maybe the business person says, well, to do my job responsibly from my mandate, here's what I see. And, is there any additional nuance that you can sort of tell me about from that?
It's actually not, I like to think, and you're not going to believe me, but there's really not much of a tension, because the overarching goal is patient first and our teams next, right? So first we have to think about what is best for a patient, and using the principles of safety, quality, care efficiency, patient experience, and then money. So when we talk about how do we make a decision, right? So it's always along that journey. Like first it has to focus safety and quality of care for the patient, and for the safety and wellness of our teams.
Right.
Then we want to talk about experience, both for the patient and our teams, and last is money. So when you start with that principle, and the patient and your team is central to that, then my nursing partner and my administrative partner, we have a great relationship, right? Like we may disagree, but it's usually not about principle.
Right.
So we may disagree on how to get there, but because we agree on the principle, there's really not a tension that I would say exists at work.
That's really good to have, I guess, guiding principles of how you're all making decisions, right? But the times when I've seen, so I guess my part of the university is a bit different. But thinking about, sort of like there's usually academic priorities, and then there's sort of student priorities, and then there's donor priorities, I guess would be kind of the triad for us. And actually, usually for us, it's like, I think we actually kind of follow a similar path, although safety isn't usually
right.
Like it doesn't come up that much.
It's a good thing.
Right. But I think it's quality, it's experience, and it's finances. And I guess it does kind of make sense. But I think that even within that frame, you see it a bit differently as you're coming from, different perspectives, and have in moments where there's like resource constraints, I think that's when usually the slightly different perspectives can be challenging. But yeah, I mean, hospital's running pretty well, so I guess it hasn't been, too challenging. But
No, I actually think it's important to have differing perspectives. For a healthy organization, it's important that people represent different viewpoints, and that's why diversity is very important, diversity of experience.
Mm-hmm.
We talk of diversity, but I think for a healthy organization, it's very important that we have differing viewpoints and different perspectives, and we represent different professional experiences, because you represent what you've learned and what you view. Your perspective is different than my perspective,
Mm-hmm.
and by we'll make a better decision if we are paying attention to all those perspectives. Because if we're always agreeing with each other, we will end up going down the wrong path sooner or later.
Yeah.
So we need that cross-checking, and that's why I think that diversity is very important. That's why I think the triad model works very well.
Yeah. Let's go down that path a little bit, actually, because do you think that, so your background and your story from how you've gotten to where you are today is quite different from many of your colleagues. You've seen health systems in multiple countries. You did your medical training in India, and then you did was it residency in the UK?
Yeah, I did like what would be considered a residency in United Kingdom.
Yep.
Got to see the National Health Service, and then I came to the United States.
Yeah, to Cleveland Clinic.
Mhm.
And there you were a cardiologist, but not an administrator.
No, so in Cleveland Clinic, I actually just did my training. So
Oh,
I did
okay,
my
gotcha.
residency fellowship, and as a faculty, I started at University of Michigan. That was my first faculty
Gotcha.
position.
Gotcha. And bleeding blue ever since.
I know.
But so tell me, how do you think that background that you've had has informed your perspective in improving the diversity of the university hospital leadership structure?
I think it makes a big difference. And first of all, I think there is something to be said about the kind of opportunity America offers.
Mhm.
Because, I lived in 3 countries, and I don't think in any other place you have the kind of opportunity that you have in America. I know many people don't agree with that perspective, and they will say that there was always more opportunity in the past. But I think for an immigrant or for a person who's born in this country, the kind of options you have are far greater than you would have in almost any other place on the planet, especially if you don't want to follow the straight path that is sort of predetermined.
Yep.
So, having lived in India where it was purely a fee-for-service, as capitalistic as can be, right? So you were poor, you had a choice, you could get healthcare or you could buy food, and people made those decisions, right? So it was very hard to see that. And then when you were in the national health system, which provided very good basic preventative care, basic care, but would not invest in a person who has, at least in those days, if you had an unusual, very expensive need, you were on your own. And then you come to America where there is sort of this a very different system where we do really well at taking care of very complex diseases,
Mhm.
and then not so well in taking care of things that should be taken care of at
Yeah.
an early stage. So there's no such thing as a right or a wrong system. Each system reflects what is best for the society and how it has evolved. And each system will eventually try and do the best that it can within that. So I think there is I often hear the debate that we need to have a system like the NHS, and people will point to either what's in the best and what's the worst. I don't think we could have an NHS. I think what we have in America is a system that is pretty good. There are opportunities to fine-tune that. I give you that.
Yep.
But coming back from the experience, having worked in very different systems gives you the perspective of, one, understanding that there is no such thing as a right or a wrong answer. There's always something good about every choice you make, and there's a downside to every decision you make. And you have to make a decision that's best for the environment you're in. So that has definitely helped me be a little more accepting of answers that or decisions that it would have been harder for some of my colleagues because they've only had one kind of experience.
Do you think that So I want to say this in a way that's not painting anything in a negative brush. But if you look at leadership structures of Michigan medicine, or I think probably most, medical organizations around the country, they're not as diverse as we would hope they would be at this point. We have a project in the Social Innovation Challenge right now being led by some med students who come from non-traditional backgrounds in medicine. And they're, the founder of this project tells her story that she felt, she was lucky to find a mentor who was a doctor and someone who could help her realize her hopes to become a doctor herself. But she said most people from my background never would find that and wouldn't get connected. Whereas people from other backgrounds, you actually don't need a whole lot of luck because you know a ton of doctors already, or your parents are doctors, or right, you're just in this different world. And so they're building a project called Diverse City, and it's like a platform where you connect, underrepresented students at a young age to people in the medical fields for relationship building and responses to questions and help figuring out what are the steps you can take to get into this field. I think it's a really cool project. They're still working out details of how to make it all work sustainably and repeatably. But what do you see? Maybe they'll listen to this and this might be interesting for them. What do you see as some of the barriers right now to improving diversity of perspectives, diversity broadly speaking, not just in sort of the go-to terms, but in the medical field and also in advancement in the medical field into leadership roles?
Yeah, that's a challenging.
It's a big question.
It's a huge question, and it's a very important question. And I think about that a lot. So let me give you a little bit of a personal, my professional problem. So interventional cardiology has 3% of the interventional cardiologists in the state of Michigan are women.
Wow.
And that's pretty much reflective of what is happening in the state. When you think about that, right now, more than half of the medical students are women. The fact that our specialty only gets 3% is an embarrassment.
Yeah.
Right. So, I work with some very strong women interventional cardiologists. University of Michigan actually is a little different than most organizations. We've had female faculty on staff from the day I started. Claire Duvernois, who was one of my colleagues, she still is, but she used to do intervention. She stopped doing intervention. She was the president of the Michigan chapter of the American College of Cardiology. She and others, they started a program called She Looks Like a Cardiologist, because bringing in high school students to expose them to the idea that being a cardiologist is a female high school student, so that they could get the idea that this is a career path for them. And I agree with you that we need to not make these roles look almost too difficult to reach.
Yeah.
Right? It's a job. It comes with responsibilities. It comes with opportunities. But anyone can do that, right? Almost anyone, if they want to do that and have the resources. The problem is for most people, they can't see that. They can't see that far ahead. And I admire the work your team is doing because it's so important for them to be able to see different people, different perspectives. And there is a challenge, right? So there are very few women. Then if you are a minority female, there are so few of them that you can't effectively mentor everyone that you can, right? There's that much time. And that may not be your interest either, right? So
it can put an unfair burden on
right.
them.
It almost makes them feel pressurized. There's this, I recently heard this great lecture by Dr. Matina from Cleveland Clinic. She talked about the superwoman concept, where Black women are expected to be superwomen in many roles.
Yeah.
And we don't want to do that. But it's important that we improve focus on the early inflow into the system and then work on mentorship and being very deliberate about providing leadership training early. Because often people go into different paths, and leadership training is just like anything else. You have to be trained, or at least you need to acquire some skills you have to learn them. And by providing leadership training, we can help build a more diverse pipeline.
Yep.
And that's the only way we can change it.
So how do you think, say a platform like the one that these students are building, how do they get doctors from systems where obviously, we were talking earlier about how busy everyone already is and how hard everyone's been working, to respond to these crises. And it's not exactly a ton of free time when you're in the kinds of roles that we're talking about. But how do they incentivize doctors to actually participate? Because when I look at their model, I see it's a two-sided market, right? On the one side, there's like an endless supply of young people who don't have access to these opportunities and would like access to these opportunities. But the problem is, like you said, it can't be all only women who are doing the mentoring, and I think there could be a lot of value to someone, regardless of their identity, setting aside the time to connect with someone who's underrepresented in the field. To what extent do you see that already happening in initiatives that are already going on? And, what would be your advice, I guess, to this project team on how do you actually create a structure that sustainably gets doctors and leadership engaged in providing this kind of mentorship?
So, one suggestion I would have is that a mentor doesn't have to look like you.
Mm-hmm.
People always want to try and mentor a female to a female,
Yep.
Someone who looks like you. My mentors have been all very different than me. And they have been hugely instrumental in my success and in guiding me, opening doors for me, in creating opportunities for me. And, if I only looked for people who were like me, I would not have been able to get to where I am. And I mentor students from all backgrounds, right?
Mm-hmm.
So I would encourage this team to actually reach out to whoever they want to. You'd be surprised
Mm-hmm.
at the answer you'll get. It'll almost always be yes.
Yeah.
It doesn't matter who in the organization you reach out to. I bet if they were to call, all the CVC directors, the cardiovascular center directors, every single one of them will find time to meet with them and will help provide resources to help mentor them. If their interest is in hospital administration, which is probably not what is going to excite young people the most early on.
Yeah.
But to me, what's going to excite them is taking care of patients, doing research or education, right?
Yeah.
So that's the typical, the AM, the academic medical center model. There are a lot of leaders who would be willing to give their time. I actually bet almost anyone you ask will find the time to
Yeah.
mentor a young person.
Yeah. That's encouraging for them. I'm going to send this to them. So maybe you'll get an email from them now that you've said that. But so you talked about your own path in finding mentors. Tell me a bit more about that, because, this wasn't something where like you came from a family of doctors and everybody expected you to be a doctor. How did you even get the idea in your head that you wanted to be a doctor?
Oh,
When was that?
It was, I actually had a different plan. I was going to become an engineer, and I wanted to start a car company. That was when I was a kid. That was what I wanted to do.
When you were how old?
Probably like in 7th or 8th grade. That's when I came up, or maybe, around that time I decided I was going to create cars, and I had even the names figured out what my cars were going to be called. And then when I was in 10th grade, I had a grand aunt who was sick, and there was a physician, Alexander Zachariah. He took care of my grandfather. He was taking care of my grandfather's sister, and he was one of the most impressive physicians I've ever met. And what was impressive about him was how he connected with people. And I go back to the ability that he had to connect with anyone from irrespective of the background as the platinum standard. I'm yet to meet a physician who could connect with people like that. And I've aspired to do something similar, trying to understand who the person is. And that was actually what encouraged me to, I made a total U-turn, and I decided I was going to be a physician, and I became a physician. I went to medical school. And from medical school, I realized that I was really interested in sort of answering questions that, or rather, I was interested in asking questions. At that time, I didn't have the resources to answer those questions. And that's what led me to step out of India after I finished medical school. I went to England, but England was not a place where you got much exposure to research. And that's why I decided I was going to come to America. And, America was just wonderful because I came to Cleveland Clinic where I had great mentors. They created a sort of a sense of opportunity without creating a narrow path. And I think that's what a mentor has to do.
Yeah.
It's like being a parent, right? You want your kids to have the resources, you want them to learn the skills to be able to survive in society, but you don't want to tell them this is what you need to do, right?
Yeah.
Because then you limit their personality, their growth, and everything else. So that's what a successful mentor does.
We say illuminate possibilities.
I like
one of
that.
our phrases here.
Yes.
Yeah.
That's truly what a mentor does, right?
Yeah.
And they also are your advocates and they watch out for you. And at some point, a mentor then lets you lose, but you still maintain the relationship. I still call my mentors for advice when dealing with difficult, challenging life decisions, like what to do with a career choice. Do I stay on path A? Do I make a switch to path B? It's always good to get a perspective from someone who will give you independent, purely based on what they feel is the best decision, right?
Mm-hmm.
They have no ulterior agenda.
Right.
They're not part of the system. And they're independent, but they're also your advocate. So that helps a lot.
Yeah, it's hard. I think it's hard to have I think mentoring relationships deepen when immediate personal or professional incentives are a little bit reduced. Where if somebody is completely invested in you doing a certain thing for their own success, it's harder to have a mentoring relationship. It can still be a good relationship, but I've found for myself that some of my former supervisors are now some of my closest mentors because we know each other really well. We work together, but now we're not immediately aligned where I have to be careful about what I tell them because I know it also affects their interests immediately. It creates a little bit of that. I think what you're talking about of like a little bit of independence there where their advice to me would be based purely on what they think is best for me because it's not really going to affect them immediately.
True. Although I would say I've benefited from mentors who, there are mentors who can feel threatened by the success of the person they're mentoring, right?
Mm-hmm.
Like they can start to feel almost jealous or envious of that success. But one of my mentors, Jay Yadav, used to say that you've achieved as a mentor when you want the job that you're mentored for, right? Like or they are in a position where you would have wanted to be.
Yeah.
And he used to say that you actually have to believe in that. And I feel the same way. And I think it's very important to pay that forward. So, I have junior faculty colleagues in whose success I'm deeply vested in. And I'd be really delighted if they achieve much more than I've been able to achieve because my job is to, our responsibility in an academic medical center or in this world is to leave this world a better place than what we got it from, right? To build on what others have started and leave it in a place where somebody else can then take it to the next level. Yep. So the next level is going to be at a higher level than where you are.
Right.
And you should take pride in that.
That's true. So actually, I'm going to retract a bit of what I said. I think there's an element to, if you look at it from one angle, what I said is true. But on the other hand, a lot of like the students I mentor, I actually do have a direct interest in their success because it makes our program look better too. And I think like my current supervisor is a mentor to me, and it's good for him if we're successful too. So there can be positively aligned interests there as well. I want to go back a little bit though. So to, this time you kind of sped through, okay, went to medical school in India and then decided to go to England and then decided to go to America. But I think a piece of that that's important to note is that you're the first person in your family to do that, right? Or did one of your siblings leave the country first?
No, well, I guess you take 2 generations back. My grandfather actually left India. But in my family, yes, I was the only one.
Yeah.
But my grandfather had actually left India. He went to Singapore. And my father was the only one among his siblings who actually grew up in India. He was born in Singapore, but then he was sent back to live with the parents because he was born during the World War II. There was this whole, they had no news back home or back in India that whether the family was alive or dead. And then when they came back after the war, my great-grandfather insisted that one of the grandkids stay with him.
Yeah.
And so my father was chosen. He was a baby at that time. So I had a lot of relatives who were scattered around the globe.
Okay, so
but
there
I
was
was the
an
first
idea
one.
that it could
Yeah.
be, yeah.
Yeah.
But was this something that a lot of your fellow students in medical school were also doing, was kind of looking to where are we going to go next, or did most people stay?
Well, people are scattered all over the place.
Yeah.
But I think I was one of the first to leave right after medical school.
Yeah.
Because my intent was to actually go get training and come back.
Yeah.
And for most people, I guess in retrospect, it was a bold move to step right after medical school and say, I'm going to get my postgraduate training elsewhere. And my plan was all along to go back to India. And then I came to America. America is very seductive. It's hard to break away from that.
I love the story you've told me about the first time at Pizza Hut.
Yeah, so, Pizza Hut's, so that goes back to, there are like many interesting things about America that when you live outside America, you don't think about. So let me tell you 2. So I'll start with the Pizza Hut story. So when my wife and I just got married, we had moved to a small town in Scotland called Carluke. At that time, the nearest big city is Glasgow. So we would take the train, go to Glasgow, hang out on the weekend. They had just opened a Pizza Hut. And you had to stand in a queue to go to Pizza Hut. And they would serve you pizza with nice napkins. And it was a nice environment. So we would have like a date at Pizza Hut.
Yeah.
And we would take the train to go to Glasgow to go to Pizza Hut. So you come to America and there's a Pizza Hut everywhere. But I still remember actually the first month we would drive down to this Pizza Hut in Cleveland, and for $20 you'd get a large pizza and a big jug of Coke. And that was, much cheaper than what we would pay for in England. And I remember coming out of that and saying, I love America. and now, I haven't been to Pizza Hut for many years, but it's a good memory of pizza.
Yeah.
The second thing, I want to say was, when you live outside America, you have a different perception of America. And I think it's partly driven by American movies, but when I came first time to America, people were like, why are you going to America? And these are friends of mine in England. And there was this worry that you can expect to be mugged at any, walking down the street in Chicago.
Yeah.
So I came upon this brilliant idea that you should carry 2 wallets, because there had been some instances in those days, this is like mid-90s, where people had been mugged and they didn't have enough money, so they had been shot. So I was like, okay, that's an easy problem to solve. So I carried 2 wallets. In one, I had about $20, and I'd keep it in small bills so it looked full. And the other was the real wallet, expecting to be mugged. So when someone stuck a gun at me, I would hand them the wallet in my right pocket. Fortunately, never had to use that. But it's if you go to many parts of the world, they will still, I suspect, feel that America is a dangerous place. And in most parts of America, I feel safer than any other place on the planet, even if I'm in a totally new neighborhood. But that's not what many people think about America.
Mm-hmm. Yeah. It reminds me of when we first went to India, and we're in the airport, and it's just like this swarm of people around, and you're just like, you've got to stay with me. And some guy just leaning on us, it's different perceptions, I guess, depending on what you're used to.
Every place has a very different perception of what is public space, what's private space, how people interact, how much you can ask someone about their personal stuff. Like if you go to Scotland, you take a cab, the cabbie they'll talk to you, they'll tell you about their life, and they want to know about your life for like a 5-minute ride. They're just very friendly, very inquisitive people, and but not every place is like that. So,
Yeah. So do you think that path that you took, and it's interesting that, you sort of say in hindsight, I guess it was a bold move, but at the time it seems like you had this ambition and you were just following it. Is that right? I mean,
yeah,
did it
pretty
feel
much.
scary or anything at the time?
No,
Yeah.
no.
I mean, you never strike me as someone who is like intimidated by these kinds of things. But I mean, having gone through that path and adjusting to new places and learning new systems and not just medical systems, but just cultural systems. And I think that has to provide value as a perspective in a leadership structure in a hospital like U of M. And I think that's part of why, to pull this back to the project that the students are working on, why it's important not just for sort of justice reasons of providing opportunity to everyone, but also for just quality of, as you said, the value of diversity in decision making, of having people who have been through different experiences. And so I don't know. It's interesting that maybe your story is a little more akin to the founder of this project, who's like, well, she did find a mentor and she did sort of, figure out how to do that. But clearly it's not happening at the scale that it needs to. And I don't think the blame can go on the individual on the other side of it.
No, it does not. And I think it's a very complex issue, because I hear about people complaining about why there is, like, I have noticed within the health system, people who are who were in positions similar to mine complaining about lack of mentorship.
Mm-hmm.
When I felt there was always mentorship, but you have to ask for it.
Yeah.
Right?
Yeah,
so you go and ask people for advice, you ask them for their counsel. And at University of Michigan, when I came here, I didn't know anyone here. I came from a different system, and I built a network of mentors and colleagues and collaborators across the enterprise, right? I have collaborators in North Campus, I have collaborators in biomedical engineering and mechanical engineering, computer science, and I just build that network by just calling up people and reaching out to them.
Yeah.
And I feel, that may come more naturally to me.
Yeah.
It doesn't come naturally to many people. You always have that inhibition that the other person will say no. My answer to that usually is, then you move on to the next person. It's not.
It's not the end of the world.
It's not the end of the world. I mean, it's sort of,
right.
It works out okay. And university has tried to actually help create opportunities at a higher level for faculty to interact with each other and so on. And that has worked in part, because not all of those relationships will be successful. Some of them will be, and some of them won't be.
It's hard to predict a mentoring relationship success.
But it's at the early stage for people who are not in medical school, who are not in training, who are not faculty. How do you ensure that they have access to resources? Because it's often things like even knowing what is available, right? Like, many people are put up by the high cost of medical school, high cost of going to college, high cost of going to engineering school, recognizing that there are resources for them, but the fact that they don't know might be enough to make them feel that this option is not an option for them.
Yeah.
And it's a challenging, racial and diversity issues. I think we have to start with investing in society. We have to provide education, provide resources that help open doors at an early stage.
Yeah.
Because that it's an economic problem.
Right.
That's how I see it.
Yeah. Yep. For sure. I mean, and that can't all be placed on any single institution, right? It's a broader thing, but
we have to do our part.
Right.
We have to do our part.
Right.
I agree. And I again go back to what I mentioned earlier, which is, if your team is, if their goal is to connect people who are early in their career or even thinking about a career, to meet with physicians, to create a system where they have exposure to physicians, I bet they can find a lot of physicians at University of Michigan. Independent of what specialty, there'll be a lot of people who will willingly give their time. They will create time.
Yeah.
Because it's really important to people. All of us want to make sure the next generation is there to take care of us when we are sick, right? We want to make sure they're the best doctors 20 years from now, 10 years from now. So we're vested in that. That's part of our professional duty. And I don't think anybody should worry about not finding mentors.
Yeah. It strikes me too that we've talked about this a lot longer than I thought we would, but I guess you're welcome to this project team. But it strikes me that building self-confidence is a big part of this as well. I mentioned that I wanted to dive into something you said earlier. It's a good time to come back to it. That when you were tasked with hiring someone to do this first, administrative role that you ended up doing, you went and said, I can do it better than any of them. Like that it takes real self-confidence, I think, to say that to your boss at the time, right?
I didn't think of it like that, but I guess that's true.
It's another one of those things where it's like, that sounds kind of bold.
Yeah. Well, no, I didn't think of it as bold at that time because I believed that.
Right.
I was a better candidate than that person, and I knew that I would do a better job. So.
Yeah. But to go and say, I know I'm not supposed to be a candidate. I'm supposed to be the hiring manager, but actually I'm going to be a candidate is, I think that's something that I've learned from you as you've sort of mentored me in the last year, is that in big systems like this, and I think in your case, it's not just in developing into a leadership role, but it's also as, an inventor working in entrepreneurship, and it's with your statewide cardiovascular collaborative, working with other institutions. Whenever you're working in these kinds of contexts, if you don't advocate for yourself and believe in yourself, nothing's just going to be handed to you, because there's very little incentive to act oftentimes unless somebody is really advocating for something. And I definitely didn't feel comfortable with that until recently, of actually saying, oh, well, if I think I can do a good job with something, I need to be making that case. No one's going to just like make that case for me.
I think people will make the case if you make the case.
Right.
So I think you have to first start with, because there's this, people aren't sure what you want, right? And the second thing is, you have to have delivered results.
Yeah.
You can't have the expectation that you are somehow entitled to something, right? So the expectation is based on your track record and your performance when you get that position. And I think as a leader, one of the most important things is accountability. Mm-hmm. You have to hold yourself and you have to hold your team accountable, both for the success and the principles. You want to make sure that you don't deviate from your principles, and you make sure that you deliver what you're supposed to deliver. Now, sometimes your destination will change, and that's okay. Your principles shouldn't change, because if they need to change, that means your principles were wrong in the first place.
Right.
But you should be honest enough to admit and look at that. And you should always be looking at things: what is ethical, what is moral, and what is your direction? What does success truly mean? Success is not about just being recognized for something. Success is, have you made a meaningful change?
Yep.
Right. And if you focus on that, people will recognize that. But to then get a larger opportunity, you have to be able to make your case, and you should feel comfortable making that case.
I think that's the thing that prevents a lot of people from advancing, and probably connects to the conversation we were just having around diversity and access, and underrepresentation, is that, the confidence to not only do a great job, but then say, we did a great job here and we should have more opportunity, both for teams and but I think especially for individuals. I think, it can be an uncomfortable thing. It has been for me to recognize that everything is collaborative, right? And everything is team-based. And when you're doing the work, you want to focus on being the best team player you can. But then oftentimes, to create opportunities for your team, you have to also talk about yourself as an individual in certain contexts. And I didn't fully understand that. I thought almost they were in conflict until I realized that my team was expecting me to advocate for myself so that we could open up more possibilities for all of them as well. But I didn't understand that, and I think you've really helped me kind of recognize that it's not hubris to speak honestly about the belief about the good work that you're doing and try to get more support for it.
I think sharing your success is so important.
Yeah.
The team needs to see that, and for your own self, you need to be able to share your success. And other people, like in an organization like the university, we take great pride in the success of others.
Yeah.
I always encourage my colleagues that we need to celebrate success more. We need to celebrate, like when a new faculty gets an important paper out, they get an important grant, that we need to celebrate that because, and they don't want to share it, although secretly I suspect they would like to share that because they feel embarrassed, right? Everyone is modest. You don't want to.
Right.
And the other thing often that sometimes inhibits people from talking about their successes, they try to put it in context of their mentor's success or somebody else who has a large shadow in the organization.
Yeah.
But remember, you're early in your career. That person was early in their career once too.
Yeah.
So at that time, they did not have as large a footprint as they have now. So we should feel comfortable celebrating success. I think it's very important to celebrate success because we often get too focused on what didn't work out.
Yeah.
When majority of the time, things are working very well and you've made a huge impact.
Right.
We need to celebrate that because that motivates us for greater success.
Yeah, there's sort of this balance between sort of self-criticism to get better, which you always want to do, but framing that in the context of a broader picture of we're moving in a direction that we want to be going in. How has that been important as a leader through this time that, to go way back to something we were talking about, earlier in the conversation, in a time when the news cycle has been so negative and a lot of that public support that you talked about for hospitals and healthcare workers in general, I wouldn't say it's evaporated. I think people probably more than they ever did before COVID are appreciative of healthcare workers and the work that's being done. But it's not not everyone is watching it and sort of like actively boosting it the way that it was at the start. How important has it been to be able to craft narratives that acknowledge the challenges, but also have a lot of appreciation and celebration of successes? What has that looked like in the last 2 years?
I feel having a positive vision is very important for a leader. We have to be able to project hope, realistic hope, because people see through unrealistic hope, right?
Yeah,
it's important that you provide a sense of realistic hope. And it's also important to be grateful for what people do. And I'm humbled by what our teams do. When you go out there and you see them do this over and over again, and patients appreciate that. We recently had a patient who wrote a letter about their long wait in the emergency room. But what they pointed out was that there were patients there or families who were openly cursing our staff, just being mean, and the staff were just being kind and just full of empathy. And to me, that's being heroic.
Yeah.
Anyone can show up to work, not anyone, but many of us will show up to work, take care of a really sick patient, even when there's some risk to us, and when everyone's grateful. That's very rewarding. But to take care of a patient who is being obnoxious, being mean, and just being, difficult, and still treat them with kindness and empathy. That's amazing, and that I think I always am impressed with that health worker because to me that's truly heroic.
Yeah, I had a previous conversation in an episode that will be, released along with this one at a future date, but. With Jerry Anderson. Was the CEO of DTE Energy for many years and is now the chairman. And he talked about leadership in the context of saying it took him years to realize that leadership is all about people. It is about strategy and it is about numbers, but ultimately none of that matters as much if it's not about people. And it's interesting that your first response to thinking about how to be a leader during a time like this was to talk about the empathy and the compassion and the gratitude for just the very human interactions of being kind while someone is being, unkind.
No, leadership is about people.
Yeah.
I think everything else, if you don't think of your team, then you're just an individual.
Yeah.
Right? Even if you're at the top of a team, you're theoretically in charge of a team, you have whatever title. If you're not thinking of the team, you're not thinking how your team's going to be successful, then you're not a leader. You're just an individual who happens to have power over other people. To be a leader, you have to invest in your team. You have to make sure your team is functioning well. You make sure your team has the resources they need to succeed, and you have to take care of their well-being. And you have to create a freedom for the team to succeed.
Mm-hmm.
You know, the freedom is important. You don't tell people this is task A or B. It is how can they achieve their potential. That is what a leader's job is.
Yep.
And you know, there are many good leaders around, and not every leader has a title. And
Right.
I'm actually amazed at the number of leaders that the university has. I
Yeah.
learn a lot from people all around in different leadership roles who are just fantastic leaders who are greatly vested in their teams.
Is that what you look for in your own team as well, of sort of emerging leaders being the people who are invested in other people's success?
Absolutely.
Yeah.
You know, like when I was looking for someone to take over my last position, or when I'm hiring somebody for any other position, the most important criteria is how much are they willing to invest in others.
Mm-hmm.
That's perhaps, and their focus on the principles
Mm-hmm.
and their focus on people. Everything else is secondary. What they've achieved of getting to that point is not as important as their performance with respect to how they deal with people and how they help support teams.
Yep. Which you know, that provides another incentive to do things like mentoring and others, right? Because if that's part of the criteria for what leadership and advancement looks like in an institution, it creates, I think, a really healthy culture of people feeling like I'm not doing this at my own expense. Although to the point that we made earlier, there are certain people who get unfair burdens, the superwoman kind of thing. But in general, if it's seen as a way to show leadership by helping others and supporting others, I think it's a servant leadership model. It's kind of what we've tried to embrace and optimize too.
Right. But I think mentorship, some of it has to come from within.
Right.
That you have to
Yeah.
truly feel that is important to you. You're not doing it to check a box on your CV.
Right. Right. I think that's the sort of interesting thing that I've been just working through in the past few years is like, how do you sort of combine the just like purely intrinsic motivation for something with the recognition that systems are built around extrinsic motivations as well. And you have to find a way to sort of weave them without corrupting either of them, which is, it's a bigger challenge than you'd think. You know, people, you hear a lot about people like getting into something for the right reasons, but then losing their way or something as they pursue some external motivation. But if you're in it for the right reasons and you never think strategically about the structures and incentives that exist, then you're not actually going to be able to do as much of that work. So you actually have to engage, I think, in both of these spaces.
A lot of fluid goes in also.
agree.
So a lot of
You know,
fluid's gotta go.
You have to maintain sort of the middle.
So
Yeah.
Either
Actually, before we
extreme
move
is
on
not a
to
practical
talking
extreme.
about entrepreneurship, I wanted to ask
Well,
you.
I want to ask you a little
one
bit more
thing
about
that you had mentioned to
entrepreneurship
me.
because this is a cross.
Shortly after you
I
took
need to use the
on
restroom first,
the-
so let's
the
take
chief
a
clinical
3-minute
officer
break.
role.
That's all right.
It was just within a few weeks, you said one night, this is basically the same thing, just the numbers are a multiple larger, that you're in terms of what you're looking at and the decisions you're making and the sort of impact of those decisions, which I thought was kind of an interesting insight. And I've heard that from other people in different kinds of ways too, that as you move up, you might be more ready for a larger role than you realize you are. And that role might be, the importance of the decisions might be a bit bigger, but the sort of actual practical process might be similar. Do you still feel that way? And in what ways do you think it is the same as you rise? And in what ways do you think it might actually be qualitatively different?
So I think in a fundamental elementary level, it's the same. The sort of the detail work, how you do it becomes different,
Mm-hmm.
right? So I am not like the stakeholders change, their positions change, so they're at a higher level.
Yep.
So I have to work with a different set of stakeholders, but the principles remain the same. And then I have now a team to whom I delegate that oversees the team to whom they delegate. Right.
Right.
So there's like another layer that has been introduced. The second thing that has changed is my ability to invest in my team. So now I have more resources that I can leverage. And the good thing was my former boss was very good. If I had gone to him and said, we need to do X, Y, Z for our team members, he was always supportive. He would find resources and all that. But now I have to think about what investments we have to make in teams that they have not thought about, right? Like it's easy to invest in something. The team comes up and says, this is what we need for a job. But I want them to be successful for their next job. And how do we ensure that there is a structure that is like how we look at our structures and how do we make them more robust? How do we create accountability within the system? How do we create more flexibility and resources within the system? And how do we ensure that principles of wellness, that is something that has been not traditionally, we talk about wellness, but people haven't figured out how to invoke wellness or to think about wellness when they're making decisions about structure, staffing, how operations are run. But that also plays a key role in how we make decisions. So all those things I have an influence on, which I did not have earlier. So it's similar, but it's not the same.
Yeah. You get more of an ability to change the structural pieces, I guess, as you go higher, which then, like you said, creates changes for the future, not just the present. So you actually introduced something there that I want to go down another path before we get to the entrepreneurship conversation. The wellness thing. So I see this on the academic side of the university as well. And a lot of people are starting to recognize this now, but I think there still hasn't been an understanding of, well, what do you do with this recognition? Which is that I think previously we sort of thought of wellness as a separate thing. Like, oh, we want to work on wellness on campus for, student mental health. Well, you need to hire more counselors and more therapists in the counseling and psychological services office. Now, I think there's a much broader recognition, and many people have been recognizing this for a long time. I don't want to do a disservice to the people who have been saying this for decades, but it's actually not just about having a separate office to deal with the most. If you're in a river, I thought of this analogy, and then public health people have told me this is actually a public health analogy, so maybe I ripped it off from them. But it's like putting a lifeguard station right before the waterfall is not the answer to wellness, right? It's about having things way upriver that are helping people avoid getting to the waterfall at all, right? And having sort of stations to move off the river at the safer times when the current is slower, and also building resilience to learn how to swim better, so you're not ending up there, right? But that involves changes to the structure of the whole academic enterprise of the university, right? It's looking at things like credit hours and grades and what kind of role are these playing? Are they helping people succeed, or are they placing a larger burden on people? The answer is probably both, and so it's complicated to know what to do about it. But how are you seeing that in the decisions that you're now making? Because you said you're trying to get wellness into the structural pieces. What does that look like for you?
So, I want to actually come back to the academic part. That's hard, right?
Yeah.
Because in some sense, academia is about getting you ready for the rigors of life and creating an environment where you know that you have to work much harder than you need to, right?
Yeah.
So you can then make a decision how hard you want to work. But then I want to switch to a practical example of wellness. So let me go back to my time at Cleveland Clinic. So the first day I was in the cath lab, I started my last case at 11 at night. And then there was a case after that. So they said, the first year fellow, you get to go home. And they started a case at 1 in the morning.
Mm-hmm.
That's not a good environment, right? So a team that has been working from 7 in the morning should not be doing a procedure at 1 in the morning, or even at 11 at night. Right?
Yeah.
So a few years ago, I was talking to the chief of the cath lab from Cleveland Clinic, and they've totally turned this around. So they've built their structure such that their lab is essentially done by 5 p.m. because they realized that running people, you can squeeze more cases, but you pay with burnout, you pay with mistakes, you pay with just poor experience, right? So They've tried very hard to make it so that they'll run more rooms during the day, but try and finish on time so people are expected to go home for dinner.
Yeah.
And that's a very sort of practical, structural approach
Right.
to ensuring wellness, because the boss is setting the expectation that everyone has to be out of the building by 6.
Yeah.
It's good business sense. They're not paying that much in overtime. They're not having turnover, so they don't have to train a new person, get them ready. So they're not losing money there. Patient experience is better because from a patient's perspective, much better to have a procedure done
Yeah.
and go home the same day than start at midnight.
Right.
And it's a really fundamentally different way than has been the tradition. So, fortunately at the University of Michigan, we never had such an extreme culture,
Yep.
but still there are opportunities for us to do better. So we're going to think about how do we build team wellness into part of how we operate.
Yep.
And that will help ensure that and make sure that we have adequate amount of staffing, adequate amount of resources, so that people don't feel overwhelmed. And ensuring that people have time off, it's important.
Yep.
There are companies that are actually enforcing time off in Europe, that you have to take time off.
Hmm.
That'll be hard to do in America.
Yeah.
I personally have been guilty of that. I don't take all my vacation, but
Yeah.
My secretary has been very good at telling me that I need to take time off. So I need to listen to her more. But it's for all of us, I think it's important to be able to take time off and relax and recharge.
Yeah.
It's good for the organization.
Yep.
Our efficiency goes up, our output goes up, and overall, the organization does better when all the team members are doing better.
Yeah. Yeah. That's kind of an interesting thing as a leader, where, I know you personally, you find a lot of meaning in your work and you like to work, and, you're not working a 40-hour week, right? I don't know when the last time you worked a 40-hour week was. And it's not because you're working less than 40. But on the other hand, so, there's a value to the intensity of doing something that you really care about and doing it hard as well as you can, right? And there's a value to being able to commit to, like you said, the level of work that you want to do, right? And there's certain elements that, like, you can't actually never be available after 5, because sometimes someone has a heart attack at 2 a.m, right? And you have to get up and go. But allowing space for people to have the freedom to invest however much they want to invest, but not create a culture where people get there and feel like, oh, wow, I need to work 80 hours, It's kind of a hard balance, actually, because you don't want to limit someone like you or like me and say you cannot work more than this many hours. But on the other hand, you don't want to create a culture where everyone feels like in order to do the job, you have to be one of these workaholic kind of people.
Right. No, I agree. And I think we have to allow people to do what gives them purpose and meaning. We are addicted to our work. I admit that. But at the same time, I think if we can create structures that don't force people to spend their life at work, that will help create a culture of wellness.
Yeah. I think it's important also to have, within, whether not even just within hospital structures, but within any sort of organizational setting, to have opportunities to have a perfectly good career where you're not trying to advance to higher and higher levels all the time. Because it's hard to imagine a future where the top leadership roles are not working a lot more hours, right? Because that's the nature of that kind of role. But there are some companies where it's sort of like up or out, and that is not, I don't think that's healthy. I think that there needs to be spaces to say, I'm going to have a good career being a great contributor to this overall organization, but I'm not trying to make it to the top. And so, and that should be accepted, I think.
I think we also, the good thing is I feel that at least in the health systems, there are many places where you can stop and be perfectly satisfied. I've known some very good leaders who took what I would consider lateral moves or downward, what would be considered on a org chart, a downward move.
Yeah.
But because they said that's where they were the happiest.
Yeah.
I know a very strong nursing leader who did that, and I know many physician leaders who did that.
Yeah.
They felt that they were happiest just taking care of patients,
Yep.
teaching medical students or teaching nursing students, and that's what they wanted to do. And that's the decision. And I admired them for doing that because they had in some sense, the wisdom to understand what gave them the perfect balance and a sense of purpose, and that's where they wanted to focus their energy.
Yep. I think that's an important thing for students to understand, is that you don't always have to be striving for something higher, right? You can actually recognize, I'm happy doing this work and I want to do it as well as I can, and that's my striving.
Yeah, I think the striving, you have to be striving, but what you strive for is not necessarily a position.
Right.
You have to be striving to be the best at what you want to focus on, right? So it doesn't matter what your job is.
Yeah.
Be the best at that job. If that's what motivates you, you should find the job that motivates you. That's important.
Yep.
And you should try and have your job be something that you find purpose and energy from.
Yep.
But then be the best at that.
Yep.
It doesn't necessarily mean that you have to go one step higher.
Yep.
And if you're not doing that, there's nothing wrong with you. I think that's actually perfectly fine.
Right.
And many organizations, healthy organizations, there's very little turnover. People are happy doing what they're doing, and
Yep.
they do it well, and they take pride in that. And they're recognized for that. They're celebrated for that.
Yeah. Yeah. And I think, you're actually in a moment of thinking about, okay, you're in this role now, which is a high level administrative role, but there are costs to that of not being able to do as much research, not being able to do as much, invention and entrepreneurship and other things that you really care about. And, you can talk about this to the extent you want, but there would be paths for you out of this to either try to become a president of a system or something like that, or there would be paths to you saying, I'm going to go focus on my research and have my lab and do, and it's not even that one is right or wrong. I think that for me, what I've been thinking about is, as I think about advancement for myself, it's like, I don't really care if I get to a higher level just to have a different title. It's if being at that level allows me to do to complete the vision I have in a way that I can't at the current level, then it's worth trying that, and worth trying to pursue that. But on the other hand, I think that sometimes I've known academic leaders too, who rise up in the administrative track and get to that level and then realize I never get to teach anymore. I don't get to, and so they say, I'm going to go back to the faculty and I'm going to focus on teaching and research because that's what I actually love. So I think it's important for those stories to be told too as success stories, not as failure stories.
Well, that's actually the true success, when you know what you want and you go back to doing that.
Right.
And I, that's what I love about being at the university. That's one of the greatest advantages of being in an academic medical center. I get to be a doctor. I get to be a researcher. I get to be a teacher. I get to be an administrator.
Yeah.
And I enjoy all aspects of that. So I have a pretty good balance. And I've, in the past, briefly entertained jobs elsewhere. I've looked at them and I realized that I would have to give up either being a doctor, being a teacher, being a researcher. And that wasn't a bargain that I was interested in.
Yeah. Yeah. Let's spend the last little bit of our time here talking about some of those other elements of what you do. So, we've been talking a lot about teams and collaboration and leadership. But when we talk about collaboration, sometimes in your role, at least, there's actually collaborations with other institutions through this statewide consortium. And then also with engineers and business people and investors in the projects that you have going with inventions that you've made. I guess we could go down either path, either talk about the statewide consortium and kind of the dynamics of that, or talk a bit more about startups and how you see, that as part of your life.
We can talk about both, because I think both are, I believe that both are very important to my sense of what I feel purpose.
Mm-hmm.
So what we have in Michigan is something truly unique. We have a collaboration of all hospitals in the state that do angioplasty and stenting, getting together to share best practices, look at data, look at outcomes, and help improve safety, quality, and just the overall state of affairs of how we provide care in the cath lab across the state. So, there was a collaborative, the BMC2 collaborative, that started 25 years ago, way before I came to Michigan. And I took over the leadership in 2010, when the former leader, Mauro Miscucci, he left to go to University of Miami. And at that time, we had almost all the hospitals, but not all the hospitals. So we expanded that to bring every hospital in the state be part of the collaborative. And it was like, along with me taking over this leadership, there was also leadership change in many of the other hospitals in the state. It was just like there's a leadership change, and it happened within a year or two in many hospitals. So there were many young, by young I mean not so much in age, but like they were just new in their leadership role, leaders across the state, and we've sort of grown in a leadership journey together. So colleagues from hospitals, big and small. And what's fascinating about this is, like I have a great relationship with people at Beaumont, Henry Ford, Spectrum, but also small hospitals, like hospitals, community hospitals in the state. And when we look at which hospital has the best outcome, you'd be surprised. No hospital has the perfect outcomes.
Mm-hmm.
So every hospital has something that they're doing really well and other things that they're not doing so well, or they have challenges in one aspect of care or another, and how we learn from them and share best practices and implement those best practices. It's just awesome. What I've found is hospitals that might be competing for patients, because we are kind of isolated in a sense in Ann Arbor, University of Michigan. We don't really have competition. But if you look at hospitals in greater Detroit suburbs, there are hospitals that are in different systems. They're competing. They may be within a mile of each other. They're competing for patients, yet they're collaborating on quality. Right? That's just absolutely fascinating.
Yeah.
And it goes back to the purpose of why we are in healthcare, which is to help others. And if my patients do better, but by learning from me, your patients do better, then I'm helping your patients. It serves the purpose that the higher purpose that healthcare is about. So we're also fortunate that we get funding from Blue Cross, and that has helped keep this engine moving. It has been hugely impactful. It has saved money. It saves money for payers. It saves money for patients. It's resulted in a safer, higher quality care. So there are, there's like no doubt in my mind that people in Michigan have gotten much better care, independent of where they show up, because of this collaborative. And they're always getting care that keeps advancing, because medicine advances, guidelines change, and how quickly those get implemented in the state compared to the rest of the country. We've seen multiple evidences of that, where a new practice comes, and because we have sharing, we track the data, we inform how every practice is doing, that there is a rapid adoption of best practices, and that then results in better outcome for patients.
That's so interesting. So tell me just one example maybe of, say, how this information sharing happens.
So, we have, right now we have, because of Zoom, we have bi-monthly meetings.
Mm-hmm.
So, just recently we had an expert, and we bring in experts from around the world. So there's a new class of drugs called SGLT2 inhibitors. So there's emerging evidence that these drugs in patients who have heart disease, they're meant for diabetics, but in patients with heart disease, their benefits are really impressive. They lead to improvement in quality of life as well as how long people live. But they are significantly underused. So we looked at the data. We found that there was an opportunity here. We brought in a speaker from the Brigham who came and talked about sort of the practical aspects of not just saying how good these drugs are, but how do you prescribe it? How do you identify the right patient? What do you monitor? And so on. And literally, like, now the data are still coming, but we can see the increase in the use of these drugs happening right away. We had another example like this a few years ago. We found that the patients who were getting angioplasty, so we used to do angioplasty mostly from the leg, and then there's been an increase in doing it from the wrist. And the drugs that we were using to reduce bleeding are pretty expensive. So one drug would cost about $1,000, another would cost about $10 to $20. And we found that from the wrist, the heparin, which is a cheaper drug, is just as good as the more expensive bivalirudin. And literally, when we presented the data, you could see that by next week, the practice had changed in the state. So people were using the less expensive drug, which is giving them the same kind of benefit. And that then resulted in money that's being saved across the health system without any risk to patients. We've also had some outliers where some hospitals had really bad outcomes, but it was a small hospital. They didn't really, sometimes you don't know what you don't know.
Right.
And when we shared their data that they had a safety signal with their leadership, they quickly responded because there were some practices that the hospital had which were out of line with what was happening elsewhere. They quickly put an end to that, and they adjusted, they trained their teams, and you could see the safety signal disappear in like the next quarter. So, that hospital has a higher risk of mortality that has now gone back to baseline, and they've actually become better than baseline. It's from the patient's perspective, they don't know this, but from our perspective, it's a great safety. A complication that never happens is the best complication.
Right. And you can understand why, from a holistic perspective, hospitals would want to participate in this and be willing to share their data, which is necessary for it to really work. Though I think I'm impressed and curious about how you sort of sustainably incentivize all the hospitals to share the data that they actually need to share, because sometimes it won't look good for them in the moment. I think about, I've been on campus-wide task forces and things like that, where you basically get one representative from every part of the academic, side of the university. And one thing that struck me that in some of those, not all, some of them have been very effective. We share a lot with each other. But in other ones, it basically felt like everyone was there, but no one was going to show each other their real cards. How do you overcome that sort of disincentive to share information?
Yeah, it's a fascinating fact that people can get somewhat self-protective, if they don't know the other side, right?
Mm-hmm.
So this collaborative's been there for 25 years, and a lot of these people have been coming to this collaborative, and we have open sharing of data in a way that doesn't make it look like only you, there's no downside to being pointed out that your outcomes are not good.
Yeah.
So for example, we have a meeting which used to be in February, but we're going to move it to a different time next year, where we would share data, and we would invite for different outcomes, we would invite the hospital that's the best and the hospital that's the worst to talk about what is happening. And a few years ago, University of Michigan was the worst at readmissions. And so it was embarrassing, because that's what happens with data, right? So some years you're good and some years you're bad. But this was like, not only were we bad, we were just terrible. And it was a wake-up moment for us, right? So I and my cath lab director, Stan Kikuti, we had to stand up and say, look, we are humbled that there are organizations that have significantly lower readmissions, and we want to learn from you what you're doing well. And people appreciated that we run this collaborative, but we are open and honest about where we are failing. And we discussed and we put in efforts as a result from what we learned from others. And now our readmission rates are really down. But that's what happens, right? Like, being able to stand in front of your peers, admit that you're not doing well, forces you to re-examine what you need to do different.
Yeah.
And then that results in immediate change.
That's really interesting. I mean, I wonder if the fact that the hospital is much more of a business than, it's not more of a business, but it has clearer, more immediate feedback loops on incentives than the academic side does, where I think the academic side, you kind of count on a certain amount of money coming in every year, and then it's fights over who gets to have it. Whereas I think with yours, you really could lose important bottom line metrics if you didn't address these things more quickly. Maybe.
But more important, we could hurt patients.
Right.
Right? To us, that's the first and foremost. Whether it's you hurt a patient or the patient has a poor experience, right? Like readmission, if a patient's getting admitted to the hospital unnecessarily, they may not be hurt by it, but spending even 5 days extra in the hospital that you don't have to, that's not a great experience. So anything we can do to make that patient's life better goes a long way.
Yeah. It's very interesting how that is just always front and center. I think one of the things that's challenging on the academic side is that I'm not sure that student experience is always as front and center in discussions as patient experience is as front and center in the medical side. And that's something that I'm always trying to advance. but there's just slightly different, I think, nuances to how the operations work, that it's sometimes harder to have the student experience be the driver of the decision.
Well, I think it's one of the drivers of the decision.
It's
right?
certainly it is.
And I think what happens is in healthcare, patient safety, the quality of care and patient experience, it's hard to argue with that.
Yeah.
Because that sort of is always the primary focus of what we should be striving for.
And I think also in that case, if things go wrong, it can be really bad immediately, right? Like if someone can have a true. Whereas on the academic side, it's more arguments over nuances of like, what does it mean to have a great, education? It's harder to say than, because it's harder to say than a case where it's like we know that this person shouldn't have been back here and that they're with us it's like, well, you have your opinion, I have my opinion about what a good education is. Even what you said earlier about these discussions around how hard should students be pushed are hard to. Those are difficult discussions as well. So I think that that's part of it too. Is that on the academic side, it's a less straightforward conversation around what is good and what is bad, which makes it harder to just say, look, we all agree this is bad, this is good, so let's just focus on.
Yeah. Anytime you can quantify something, you can measure it, it becomes a lot easier to address.
And education is one of the hardest things to quantify. Everyone knows it's probably the most important thing because it's the root of everything else. Even, you say health and education are always the two sort of like core needs that people have. But ultimately, health is built on education as well because...
absolutely.
Yeah, so
I wouldn't disagree with you at all.
So education, we all know it's really important, but we have a very difficult time quantifying anything. Not even just the outcomes, but even just the inputs. What are the right, what are even the factors that you should look at? It's we could go down that road, but I don't think that we have time for today. So maybe that's a future conversation. But
well, plus I profess to no expertise on that. I have no idea what makes for a good education.
Yeah.
I can tell you, I have colleagues, I admit, I have colleagues who are very good teachers. And teaching is a skill, and maybe we don't teach it as well as we ought to. I know, our colleague, Eric Bates, he's a much better teacher than I am. I admire how he can systematically sit down with every person and teach them on how to interpret a catheterization film, right? He'll go over it with every fellow, and he does it so well. I always admire how he does that. And I feel like every student who could should learn from him how to interpret a cardiac cath film. I've tried to do it, but I know that I don't do it as well as he does.
Yeah.
And I admire that because it's hard to quantify. I can look at it from a distance and I know that he's better than me. But how do you measure it? How do you rank it, right? It's just is a challenge.
It's very hard. And you can't just ask students either who they prefer because it doesn't get you at the real thing.
Right,
it gets you how much they like the person.
Exactly.
Yeah. So that's hard too, which is why even faculty rankings based on, the student surveys of assessing a class, it doesn't actually get at the key question. So they're useful in a way. If someone's really, really bad and they get a bunch of really bad reviews, that tells you something. But anywhere from pretty good to really good, it actually doesn't. You don't know who's actually where they are on that spectrum in a true sense, which is very fascinating.
And if you think about it, what is the role of education? Sometimes you won't know that for a decade later
or more.
And
for sure.
And it's not easy to measure. So, tough question.
Yeah,
I'll let the experts figure that one out.
So, sort of final topic here with our last 15 minutes, but another part of your sort of self-identity is as a inventor and a co-founder of various different companies and sort of products, particularly the product side of things, not the drug development side of things. When did you start doing that?
So I grew up on a farm, right? So on a farm, you have to be innovative. Actually, I think farmers are innovative. I've known farmers in India. I know farmers here, and they have to figure out things on the farm with the tools they have.
Mm-hmm.
So, and what I do in my clinical side of things is pretty much like working with tools, right? It's interventional cardiology is all about trying to fix a problem in the heart from a distance, right? So it's totally tool-based. And every time you have something that's tool-based, you recognize that there's a need for a better tool for A, B, or C. So coming up with an idea on how to solve a problem is actually not that hard, especially if you can connect with the right people, recognizing that I want a tool to do A, B, and C. Then you have engineering colleagues who can help you solve that problem because they don't know the problem exists. They can't solve it by themselves.
Because they're not the one doing the procedures all the time, right?
So having that relationship, that has helped me a lot. So I've had a relationship with mechanical engineers. Albert Shee has been someone with whom I've worked for almost since 2006, 2007. And we've had a long relationship. We've published a lot of papers. We've developed many products together, usually through a student of his working with me. But not everything turns into a product that is used in a human, because an invention is easy.
Yeah.
Converting that into a product that then goes through the regulatory process and everything else is pretty hard. And so we have two products that one got licensed to a company in China that's actually building it. They've been testing it in animals, and they're ready to move to humans soon. Then the second, one of my, so I was working with a postdoc, Robert Chesina. So he and I started a company, and we started it actually during the pandemic. We had to raise money during the pandemic, and we're quite excited. The company was originally called Calcium Solutions, and after we went through a first round of funding, the VCs wanted to change the name. They said Calcium Solutions sounds like a chemicals company.
Yeah.
Because it's focused on treating calcified plaque. In my world, calcium is only calcified plaque. In the rest of the world, the calcium is something very different.
Yeah.
So they asked us to change the name. So now it's called Amplitude Vascular. So we are ready to do our first in man this year. So we're quite excited about that. So the device is ready. It's it'll be impactful, because to me, our success is when a device is successfully treating patients. So I'm quite excited about that. It was a huge journey. I think starting a company is way more complex than almost anything else. And it's also, if it succeeds, it is the most meaningful thing that I would have done, because you develop something from a concept to a prototype to an actual device, get it through regulatory approval, and to get it into human use. That would be the most meaningful thing.
What did the prototyping process look like for this company?
So we started with some work that was done in HHDAO on North Campus, and a company that we worked with in Germany that does prototype development for us. Because some of it is we had to make devices that are medical grade to be able to assess if this works. So this company, I have a long relationship with them. They've helped build prototypes for us. So between those two...
Is that like what they do? They're like a prototype building company that works with others? Or is it sort of just a wing of what they do?
They are like a medical device company, but they have something where they develop early stage prototypes.
Oh, that's cool.
So it's something that they've done for a long time, and they do a very good job with it. And
so you send them specs of kind of, here's what we need?
Yep. And so they are very good. They're very meticulous. They go through everything, like check and check and check. Drive you insane with the level of rigor that they have, but then they develop the product, and it's exactly what you wanted, right? And so I can understand why they go through those spec validation over and over again.
And when you say spec validation, that's coming back to you with more detailed questions each time, basically?
Exactly.
Yeah. That's got to be such an interesting job.
I don't know. It gets kind of boring job, right? Like,
you think so?
In my mind, this is, I want something that looks like this, and the engineer should figure it out. The engineer wants the precise, exact specs, and but they're very good at what they do. So, we did that, and then we tested it. We tested it in pig model. We tested it in cadavers, because there's no model of plaque that exists. So we tested in human arteries from patients who had surgery, and then in people who were dead and had donated their body to science. So we did all that, And then we raised money, we did some more testing, and now we're at a stage where we are ready to go in first in human. That will be done outside the U.S. because it's just the regulatory cost of doing something like that in America is very
Is
high.
high. It's really interesting to hear you describe that process because it's in some ways it's very different from what the average student-led project, would be working through. But in other ways, on first principles, it's basically the same. It's like you identify some sort of problem, something where the current tools available aren't working well enough, and you come up with a concept for what an initial test of this would look like, and you do need to do the specs. And I think that's why I actually think that process might be kind of interesting, is because it's almost an educational. You're almost like an educator and a researcher and a engineer all in one, trying to help the person who understands the problem understand how to give you the right specs. And then basically what I oftentimes will tell students, even if they're doing something like an educational workshop and they want to work with, maybe like fourth grade kids in some school district, and maybe it's sort of a underserved school district, I would say oftentimes, well, you got to develop the plan for the workshops, but then you should do them several times with like your friends and family or like other college students who are just low risk audiences, where if you learn something about your specs that you didn't expect, you haven't actually done harm to the more at risk audience. It's kind of the same as putting the device into someone who's already dead. Is like, you're not going to do harm to this body. But if you went straight to a living, there's that whole process. It kind of tracks with the prototyping process that we try to help people think through, even if they're doing things that aren't life and death, but could still carry risk. So
I think students should look into these things.
Yeah.
And because, we have a device, it's a novel device. There's nothing like it, right? So it's not like we're making a better cell phone, or it's not anything there's nothing like this exists. So what a regulatory path, what our testing strategy is going to be is all new. We have to define that. We work with the FDA on that. And I have to give credit to Robert Chesina, who was a student and who felt passionate about it. And so he and I, when we started the company, we basically split it 49-51. You never want to have a 50-50 because then you'll be fighting over decisions. So we split 49-51 because he was vested in it, and I felt that he had the energy to make it work, right? So he was passionate about it. He was thinking about it all the time, and he was absolutely the right person for it.
he had the 51.
He actually took 49.
He took 49.
Yeah,
Okay.
It was. I would have given him 51, but he said, no, you take 51. We have a very good relationship.
Yeah.
So we could have done 50-50, would have been fine.
Right.
Yeah.
He's a lot younger, and this was your identification of the problem at first. That makes sense.
But it's like one person here, one person there. Doesn't make a difference. Yeah.
Right. Yeah, for sure. Well, I hope that one of those companies does very well.
I hope so too.
It's got to be kind of fun, sort of like, having these very different kinds of spaces that you operate in, because I think one of the hardest things is monotony. Dealing, even if you're working in something that you care about and love. Like for me, that's why I started this podcast. Honestly, I didn't know what this would turn into, and it's turned out that actually a lot of people have listened to our early episodes, and I'm getting this kind of unexpected feedback loops coming back to me of like interest in donating and stuff like that because they listened to an episode. I didn't even realize that would happen. For me, I just did it because I was like, I just want to have fun and have interesting conversations, because as much as I love the work that I do leading Optimize in a sort of more direct way, if that's all I'm doing and I'm not just like creating this space to have interesting other types of conversations and just exploring just a different part of myself and a different sort of way of looking at things, it can get sort of monotonous, and even something that you love and feel purpose in can start to get old. So I think it's kind of cool that, and you mentioned this, being at an academic medical center, you get to do all these different things. And, on Thursday afternoon, you get to be an entrepreneur, and then on Friday morning, you get to be a team leader. It's a very interesting thing.
Absolutely. I think I love my job, and I have probably one of the most interesting jobs that I could have asked for in medicine. I get to do things in very different domains with very smart people, and all focused on like making a positive difference. So it's one can't ask for more.
Yeah. I've told you that before, that you're lucky that you've aligned all of your incentives and interests and passions on this direction, and there's no ambiguity around like, is what you're doing good?
yeah, that's important. And I think
Yeah.
that's something about Optimize that I find fascinating. And it actually makes me optimistic about the future, because like I've been to some of your
Showcase events.
showcase
Yeah,
events, right? So you see all the young people with all these ideas, and some of those ideas will work out, some of them won't work out, but these people will work out,
yeah,
right? That's the key.
That's
thing.
the
It's
point.
not your, like, when I think of inventions, we have, like, our amplitude vascular is our biggest success so far with the funding we've raised and everything. But there are tons of inventions that didn't work out.
Yeah.
But that's not the point. The point is you got to keep trying, and you got to always be thinking about, am I making a positive difference to this planet?
Yep.
And when I see if Optimize, it gives me a sense of optimism, because there's so many young people, right? That's the future.
Yep.
You don't know what is going to be the next big idea, but it will come out of those people, because they're all thinking of how they're making a positive contribution to this earth.
Yep.
And they will change education, some will change environment, some will start a new industry, right? Somebody will, I am positive some of your students will start a new field that doesn't exist at the moment.
Yeah.
Because of that positive energy they have.
I think so too. And in many ways, the students who are on the organizing team and the leadership team are starting a new field of social innovation and entrepreneurship in the liberal arts. That has never existed. And it then spawns all these other things that go off and create their own new sort of approaches in many different ways. And hopefully helps build that confidence we were talking about at the very beginning, to say, regardless of the outcome of any one shot on goal, I'm learning how to take the shots on goal,
And you have to enjoy the game.
Yeah, right. That's right. Well, to close, I always like to ask about sort of just some sort of self-reflection on, and self-reflection is incredibly difficult. No matter how much people say they do it, whenever I really try to self-reflect, or like, you come up with a narrative or a story, but it's actually really hard, because if you try to watch your own thoughts, you realize it's all just jumbled pieces, and I don't, so I'm not expecting a perfect level of self-awareness or anything like that. And so much seems to just be instinctive and temperamental. But for someone in your role, I've, because, your family, I've had a chance to just spend a lot of time around you and see you when you come home from work, and see you when you come home from work after doing pitches to venture capitalists, or after dealing with the first days of COVID, or after, and one thing that strikes me is that your ability to compartmentalize and to just stay calm, and to, after a day where you had to, maybe you lost a patient or whatever, to just come back and have fun with your family, and that, I really admire that. And I wonder, for you, do you think that's just purely temperamental, that you just can do that? Or are there any sort of like habits of mind or practices, physically or mentally, that you think are necessary for you to be able to do that?
That's a tough question.
Yeah.
Because it's sometimes you think you control that, but you don't know.
Right.
I think one habit that I have, like at least when the weather's good, I'll go for a walk.
Mm-hmm.
I come home, and what I do is I take my dogs for a walk. It's just like a 10, 15-minute walk. And I find that helps separate the work day from my evening. And I find that very helpful. I avoid social media. So that's the other thing that I feel really helps me separate, because social media never ends.
Right.
And I see people who spend their life on Twitter.
I've been much happier in the 2 years since I deleted mine.
Right. So that has been something that helps me create a boundary between work. It's not a perfect boundary. It takes time to get over a patient's death.
Yeah.
That's always harder, especially a patient who dies in a procedure.
Mm-hmm.
It takes days and weeks before you totally, you never forget that, but you're at least able to function back to normal. It shapes you in a different way. Every patient's death that happens, even when you're part of the team, you're even around the team, you never forget that. But outside that, being able to compartmentalize work has not been that challenge for me.
Yeah. I think there is a lot of just stuff that is completely out of our control in those kinds of areas.
I think so. I think some people can,
Yeah.
and some people can't, and you can shape some of those things.
Yep. This is where, to just wrap this up, I think one of the things that I'm most inspired by in the work that we do is, we're working with, we built Optimize and the Social Innovation Challenge and that whole part of what we do. And what we started to see is that a very large number of transfer students and non-traditional students were participating. And so we ended up building specific transfer-focused programs where we work with community colleges around the state and offer social innovation programming there in collaboration with those colleges, and then have what we call transfer bridges, where starting there, there's opportunities, and then there's opportunities sort of over a bridge to come to U of M, and then opportunities on this side to really feel that you're part of a community and you belong, and to participate in these very high impact programs like Optimize. And one of the narratives that we encountered when we first were seeking financial support for these kinds of programs was a sense that students from non-traditional backgrounds or transfer students would have a hard time doing all that we were saying they could do, like not just doing their classes, but also building a project on the side and being a part of the Social Innovation Challenge, or building new programs on campus for their peers, or serving as ambassadors back to their campuses. And our argument, which the College of LSA fully supported and made with us, was that actually those students are more likely to be able to do that, because the things that they've had to overcome to even get here and to be in that, that place that they are today, is the stories you hear are incredible, right? And they've made it through so much already to get here, and there's a sense of purpose and an ability to compartmentalize and work on lots of different things because they've had to, more than a student. Not that students who come here through a traditional, like, enter when you're 18, leave when you're 22 kind of path can't do that, but oftentimes they haven't had to fight as much to get to where they are. And in my mind, that is where, and fortunately, after 3 years, the foundation that's funding this completely embraced the outcomes that we showed and said, wow, like, you're right, and put a lot more funding toward this. But to me, I think that your ability to do that is probably partly from the path that you took to get here. And I think that there's a lot of students out there who might think there's lots of reasons why not them to either enter whatever field it is they care about. We were talking about the medical field, but it could be any field. But really, I think that if you're working through obstacles now, it prepares you even better in the future to be in a situation where you have lots of challenges going on around you and you need to find a way to stay even keel through it. So that's my hope with the work that we're doing, is that we change that narrative in people's mind around sort of from like a deficit kind of mindset to an asset-based mindset.
Absolutely. I couldn't agree with you more. Students who come from a different organization are self-selecting.
Yep.
They are looking to do something different.
Yep.
They will be more successful.
Yep.
They will be successful in a different way, and they have a different kind of energy and a different drive. And anything that you can do to help support them will contribute to the success of this organization.
Yeah. Well, that's a great little blurb to close on. We might have to pull that out as a promotion for our transfer programs. But thank you so much for making the time. This was a fun conversation.
I enjoy it.
Yeah.